Hi, welcome to our fairly new Community 7 television show called Our Planet, Our Health. This version today is called Conversations from the OR. In this television show, we talk to Montanans who are addressing climate change across our state and sometimes across our nation. I'm Lori Byron. I'm a pediatrician that has practiced pediatrics and cared for children in eastern Montana for the past many years.
And I'm Rob Byron, an internal medicine specialist who cared for adults in southern Montana for an equally long time. Together we will be your hosts on Our Planet, Our Health as we talk to people from across Montana. Most will be healthcare professionals working to protect health and safety, to make the public aware of the connections between air pollution, climate change, and our health, and also working to address the air pollution and climate change it is causing. But health involves all of us, not just healthcare professionals. With that in mind, some of the people that we feature on these programs will not be healthcare professionals, but professionals in their own right, who are also working to protect our health.
So today we have Dr. Brian Harrington. Dr. Harrington is an anesthesiologist at the Billings Clinic. He's been in Billings for many years. He's on the board of directors for the American Society of Anesthesiology and does a lot of work in our community. So welcome, Brian.
Well, thanks for having me, first of all.
Yeah, we appreciate it. So maybe the first question for you should be, just tell us a little bit about where and how you grew up and your traits that you learned from your parents. And
okay, well that's an easy one. I was born and raised in Montana, and I grew up in Bozeman. And my family was a family of hard-working, entrepreneurial type Montanans. And I learned the value of hard work and just being part of a community. I think the main thing I learned from being in Bozeman, growing up in Bozeman, is just the natural beauty around us. And I've always had a deep appreciation of nature. And of course, we have to do our training outside of Montana. I went to medical school in Seattle, and I did my residency in Seattle as well. And I couldn't wait to get back to Montana. I always knew I would come back. And it's been a pleasure to be here for the last 35 years.
Yeah. Thank you. And Brian, part of our discussion today will revolve around climate change. But before we get there, most of us don't know what an anesthesiologist does. Can you tell us a little bit about that?
Well, anesthesia is a fairly broad field, but probably most anesthesia is keeping patients stable and comfortable during surgeries. But we're also involved in things like pain control, critical care like ICU care, but I would say mostly things like labor and delivery, providing labor analgesia. But most of what we do is in the OR, either providing a general anesthetic or something else. We have regional anesthesia, which would be like, say, a spinal anesthetic or a nerve block, just blocking the arm, or local anesthesia where we're just there to provide maybe some sedation. So we do a number of things, but a lot of it is in the OR with surgeons.
so I understand that you have this passion about the history of anesthesia and that you've been working on a national museum to this effect.
Yeah, actually, as I sort of head toward retirement, I think you just have such a great perspective on evolution of the specialty, and I just love anesthesia. I've enjoyed going to work every day, and I think that going forward, even after I'm retired, I'll be able to work with the American Society of Anesthesiologists. Actually has a museum that's affiliated with it, the Wood Library Museum, and it's in Chicago. And they're probably the largest anesthesia museum in the world, although it's not really open to the public. It's mostly a lot of stuff being stored. And so you've got things like archival material, letters, we've got recordings of people, interviews like this with famous people in the world of anesthesia, and a lot of equipment, a lot of stuff. You can imagine an anesthesia machine is a pretty good sized piece of equipment, and we've got all kinds of anesthesia machines. They just renovated a collections facility in the outskirts of Chicago, and I think this thing is 50,000 square feet altogether, and they've just renovated about 25,000 square feet of it for museum quality archiving for this museum. And I'm on the board of trustees for the Wood Library Museum, and I hope to do it for a number of years.
Wonderful, thank you.
So, what's the quirkiest or most gruesome thing in anesthesia that you have found in this museum?
Gosh, you'd be hard pressed. I mean, some of the things that they've collected over the years. I would say if you want to see a museum with the quirkiest things, like the old curiosity shop kind of stuff, you got to go to the Mutter Museum in Philadelphia. I don't know if you've ever been there, but that's the quirkiest. In anesthesia, it's interesting because every piece of equipment has its own history. And gosh, I'd be hard pressed to just come up with one thing that really stands out. But I will say that I did a fellowship on the history of the epidural blood patch. Now, you're probably familiar with the blood patch, and this, if somebody gets a spinal anesthetic and they have a leak of spinal fluid and it doesn't want to stop, people get a headache, they get a spinal headache. And this was a scourge of spinal anesthesia for, gosh, 70 years before they came up with what's called a blood patch. And this is a really strange procedure. And so what we do, and we still do this all the time today, if somebody has a hole that won't seal, we'll take blood from their arm and inject it into their back where they had their spinal or their epidural, and it'll seal that hole. And I did a history project on that and published an article. So that's, I think, and when I saw that the first time, I thought, now this is different. I didn't expect anesthesia to be this. So yeah, so that's one example.
Oh, fascinating. Thank you. So let's turn to climate change a little bit. Did you get interested in climate change through your work, or did you come at it from a different way, or some combination thereof?
I would say a little of both, because like I said, you know, growing up in Bozeman, I've always had a deep appreciation for this natural world that we live in, and we only get one world, we better take care of it. And but I think the thing that really sort of was an eye-opener for me is about 30 years ago, I taught anesthesia in sub-Saharan Africa for a summer down in Zambia. And when I went down there, I was your typical American-trained anesthesiologist, kind of had everything. And the guy who set up this program was a very famous anesthesiologist from Yale. And I was talking to him before I went down there. I said, well, what can I bring something? I mean, it sounds like they really have a lot of needs. And he goes, no. He goes, if they don't have a blood pressure cuff, you just need to do the best anesthetic you can without a blood pressure cuff and teach them how to do that. Because I was there just to teach, not to do anesthesia. And so that kind of got my attention. But then I went down there, and the thing that struck me was not just the inequity of healthcare around the world, but the fact that they didn't have anything that was disposable. Everything that we would consider to be disposable was, they tried to reuse it. Even things like breathing tubes, things like, if they had a blood pressure cuff, it got used forever, even if it was just the single-use type thing. And when you come back after being there for a few months, it sort of strikes you how wasteful our system is, and I've seen it over the decades now. Things that used to be reused are now disposable. Something as simple as, say, a surgeon's gown always used to be cloth, and now they're all paper. We throw them away. In anesthesia, we have a ton of equipment that used to be reused, cleaned and reused, and now it's all disposable. We've kind of just gone to all disposables, and things you wouldn't even think of as being disposable. Things like a fiber optic scope that you can look down into a patient's lungs. Well, for $300, the hospital will buy the disposable fiber optic scope. They don't have to clean it or anything, and it's incredibly wasteful to my eye to see. Really, we have really good equipment in medicine. You know, things need to be made to very high standards if you're going to be using them on patients in critical situations. These things are made very well, and something like this reusable scope, you know, if you brought that down to Zambia, they'd use that for years. We'll use it for a couple hours and throw it away. And it's really stuck with me how, you know, I came back, it was like, oh my gosh, what are we doing here? And then it's only gotten worse. Recently, however, I think climate change has become a great high-profile topic in the world of anesthesia, and it's getting the attention it finally deserves, and we're actually in a position to do a lot of things about it. So that's the good news. That
is good news. So what can you do as an anesthesiologist?
Well, surprisingly, a lot. Because a lot of things that we do out of habit. And if you do things more consciously, then you're going to end up having a lot less waste. And you're going to be using things, you're going to purposefully use things. And so, for example, it's a very common practice when you're in your training to draw up a lot of drugs in plastic syringes that are going to all get thrown away, of all the drugs that you could potentially use during that case. If the blood pressure goes too low, well, I've got some medicine here. If the heart rate goes too low, I've got some medicine here. If the heart rate's too high, I got that medicine. And you would draw up all those medicines and have them all ready. And they've shown that the vast majority of those drugs never get used. They just get thrown away. The syringes get thrown away. The drug itself gets thrown away. And a drug that gets thrown away a lot is propofol. And I think most people are aware of propofol now. It's a drug that we use for sedation. We use it for putting people to sleep. But we'll also use it as infusions to keep people pleasantly sedated. And propofol is not a controlled substance, which means it's not tracked by the DEA. And so not being a controlled substance means that you can draw it up. If you use it, you use it. If you record that. But if you don't, you just throw it away. And you don't have to account for it like, say, a narcotic, an opiate or something. But the propofol ends up just getting squirted in the garbage a lot of times. And the problem with that is that propofol does not naturally biodegrade. And so it needs to be exposed to like 1,000 degrees Celsius for a couple seconds to degrade it. And it has this propensity to bioaccumulate in nature, and it's been shown to be neurotoxic in fish species, in animals that live in the water. And so this something like propofol, if we don't make sure that it gets incinerated, which you can do by squirting it into a red bucket that's hazardous waste. If you squirt it in there, then it'll get incinerated. But if you put it in the regular garbage, typically it'll wind up in your groundwater. And these things, they've shown anywhere from, like waste disposal centers have drugs coming out of them. Hospitals, especially the sewage out of a hospital, has a lot of drugs coming out of it, and there's something we can do about it. So just throwing it away properly, like squirting it into the incinerator, it saves a lot of downstream potential effects. So
wonderful, thank you. And you've connected a lot of different things there. Actions in the operating room to the water we drink, and to the ecosystems that live in those waters, which for many of us in Montana, if not all of us, are extremely important to our way of life. Are there other things, either in the OR or within your subspecialty, that come to mind that impact, I don't want to say just our health, let's say particularly impact our climate change or contribute to air pollution, let's say.
Yeah, we are, you know, I always thought that anesthesia was a pretty clean specialty, but come to find out we're actually a carbon hotspot in the world of the medicine itself is a carbon hotspot because hospitals, and particularly ORs, are very energy intensive. They're a very controlled environment. The circulating air, the air in the operating room needs to exchange at least 20 times an hour, and it has to be kept at a constant temperature, all that stuff. But the thing that makes anesthesia really special is our use of anesthetic gases. And when we talk about anesthetic gases, we've really got two types of gases. We've got the potent gases, which would be like the ethers, and then we've got nitrous oxide, which is laughing gas. And we use both of these types of agents, and come to find out, they're both very potent greenhouse gases. And so, if you like set up a refrigerator factory in your town, I bet you the government would say, you're not just going to let that extra Freon go into the air, are you? Because we know it has a lot of effects, potential health effects, the air quality, the ozone layer. Well, all of these agents, we use them and they get vented to the roof of the hospital building and they're in our environment. And there's a couple of them in particular that are worth noting. And one of them is nitrous oxide, the laughing gas. And that's not a very potent anesthetic, so you have to use a lot of it. But it is an extremely long-lasting greenhouse gas. If nitrous oxide winds up in the atmosphere, it takes about a century for it to break down. That's a long time. So we're affecting generations of people. And not only is nitrous oxide a greenhouse gas, but it depletes the ozone layer as well. And so you got kind of a double whammy with that. The other agents, all the other agents that we use are essentially ethers, like diethyl ether, which was the first inhaled anesthetic back in 1846. But all of the agents have been modified to make them so that they're not flammable. And so we use these potent agents. And the most common one in the United States now is called sevoflurane. It's probably the safest for our environment as well. But when sevoflurane first came out, there were concerns that when we use these gases, we run them through a CO2 absorber so that when the patient exhales the gas, we can scrub the CO2 out of that breath and reuse the sevoflurane. And so there is a problem with sevoflurane being degraded by some of these CO2 absorbing agents. And so it was producing something called compound A, which was toxic to the kidneys. And so they said, well, we want to make it so that compound A can't accumulate. So we want you to have sevoflurane flushing through this really fast. And so this has to do with the fresh gas flow. And so when we have an anesthetic, if we're doing an anesthetic, we have oxygen or air coming into the machine, and then it goes through the patient. And then, of course, if we have 1 liter a minute of oxygen come into the system, well, we have 1 liter of gas coming out of the patient because their patients aren't blowing up or anything. So, so there has to be this equilibrium. And so they said that sevoflurane needed to be run at these high gas flows, and they said it needed to be run at 2 liters a minute. And since that time, they've actually taken out the ingredients in the CO2 absorbers that result in compound A. So it's not even a concern anymore, but we're creatures of habit. So you go in, people are commonly putting their gas flows on 2 liters a minute, just out of habit, even though 0.7 liters a minute, which would be 1/3 as much, is just as safe. And I was just talking to a friend of mine last night, and she's at the University of Minnesota, and she goes, we've really buckled down on that. She goes, that we will not allow people to run more than 1 liter a minute. That is like, we're really cracking down on the people that we're training. But the people that are running it at 2 liters a minute, they're people who were trained earlier, you know? So that's been an issue. There's another agent that that is in use called desflurane. And desflurane is sort of like a competitor to sevoflurane. And in that, it's not very soluble in the blood. And not being very soluble makes it so that it's a much faster acting anesthetic. So people go to sleep faster, they wake up faster. And particularly with ambulatory surgery, we want people to go home the same day. We want them to wake up fast. And people who use desflurane love desflurane. But desflurane actually is a really potent greenhouse gas. And when you think of the carbon footprint of something like an hour of sevoflurane is the equivalent of driving your car 4 miles. Well, an hour of desflurane is the equivalent of driving your car 200 miles. So they're the same, that's the same hour of anesthesia, but we're creatures of habit. People like desflurane, they like using it, and they use it. And I have a feeling that in order to get people to stop using it, they're going to have to do like they did in the European Union, where they've actually, starting January 1st next year, 2026, they're severely restricted. Actually, they're essentially banning desflurane from Europe because of this.
Yeah.
And so we've got that agent as well.
That's a great discussion, and appreciate that in a way that most of us can understand.
Hopefully.
But the other thing, let me ask this, and that is, change is hard, but to make those changes, it sounds like you're using less of an anesthesia agent, and my understanding is they're quite expensive. So is that costing hospitals money to do this?
Well, that's probably the reason that it's going to happen, is hospitals will save money by implementing these environmentally sound principles, like decreasing the fresh gas flow, like changing away from desflurane. Another good example is the nitrous oxide, the laughing gas that we talked about, and they've shown that nitrous oxide, it's usually, if it's centrally supplied for a hospital, then it'll typically be in the basement somewhere, and you'll have like a row of large cylinders of nitrous oxide. And they've shown that because now we have the ability with the electronic medical record, we can see how much nitrous oxide we're using in the operating room because it gets recorded on your anesthesia record. Well, we know now that probably 80%, at least 80% of nitrous oxide that is in those cylinders that the hospital buys gets wasted through things like leaks in the system before it gets to the patient. So they could spend 20% as much by just having small oxygen cylinders in the operating room instead of this central supply. Many hospitals around the country are decentralizing their nitrous supply, and we're actually in the process of doing that in Billings. So.
Are you aware of any success stories in the OR, either with other people working in the OR or with anesthesiologists addressing the issue of climate change?
Yeah, I would say that just the idea of decentralizing the nitrous oxide, that's a really common, popular measure that any hospital can take, and it's going on around the country. Another is this effort to recycle things that we use, and recycling in medicine is a little bit of a challenge because a lot of the things that we use have plastics that are not necessarily very recyclable. They say that they're recyclable, but there's only a couple of types of plastics that are really practically recyclable. But one of the big problems we have is when we use like any type of equipment on patients, then it sort of enters a different type of recycling process, because it has to be sterilized and recycled too. But there's a lot of people that are getting into recycling things, and we kind of color code our garbage bags in the operating room. So most of them are just clear bags, and that's for general waste. If a bag has red, if it's a red bag, that's a biohazard waste, and that'll go and that'll get incinerated. But a lot of hospitals now have implemented purple bags, which are for recycled items. And so things are identified. You want to capture things as early as possible. So really, the users are the ones who are going to be able to identify this needs to be recycled and identify it at that point. You can't have people sorting through general garbage. So we have to do it in the OR. There are some efforts. I know that there are some efforts in Scandinavia as well as Canada to scavenge anesthetic gases. And this can be done instead of just putting them out in the environment. You can either capture them and recycle them, reuse those agents. Most of the inhaled gases that we use, they come as a liquid and they're minimally metabolized by the body. So when our bodies are done with them, we just exhale them and they're gone. They don't get broken down. And so they're the same thing at the end as they were at the beginning. And so if you can capture them, which is not easy to do, and not cheap, it's not cost effective at this point, but there's a lot of people looking into it, then you could actually reuse the same gas again. Another thing you can do with anesthetic gases is you can destroy them. So you could run them through some sort of a process that would break them down in some way, like either through radiation or heat or something like that.
That's awesome. I think we've all learned a lot today. So we only have about a minute left.
Wow.
Brian is there. Anything, most of the people that are going to watch this are not anesthesiologists, nor are we. Can you give any advice from your own life to what other people can do?
Yeah, I would say that from what I've seen in the OR, I think we can apply it to our own lives, is to try to reduce the amount of things that we use. And I think that's like when I talked about the syringes and just not drawing things up. We're still going to use those syringes, but instead of using 20 in a day, maybe we'll only use 5 in a day. And I think if we just use things more consciously, we're not going to consume nearly as much. And I didn't really even talk about plastics, but I think we need to make a real effort to get away from plastics as much as possible. And so, unfortunately, plastics have really taken off, and so that's a big challenge, is to think about doing things with materials other than plastics. That would be a good take home.
Well, hopefully our leaders and the leaders in healthcare will become as conscious as you are of these issues. So,
all right. Well, thanks for having me. I appreciate it.
Thanks for being here.
Thanks for sharing your stories and your expertise.
All right.